So we've got about 10 minutes for questions. If anyone has any burning issues they'd like to raise. Otherwise, I get to indulge myself because in my new job, I have to pretend that, I don't have views on these things that these people have been raising, which is really uncomfortable on days like today. So, okay,
I'll start with one.
Go on, that would be brilliant.
The core outcome sets that you're talking about, it'd be interesting to hear what you're planning to do for this fatty liver Nash disease.
Yeah. Well, without getting into too gory details, the interesting thing about Nash is that it's asymptomatic through most of its natural history until it's so far advanced that there are early signs of liver failure. So which means that from a regulatory point of view, all of the conversation is about biomarkers, and that the effectiveness is going to be looked at from a point of view of biomarkers and other surrogate markers, not things that actually patients report or experience. So that is of course going to be a huge challenge when it comes to I think we're going to see a whole stream of these products that get regulatory approval based on surrogate outcomes with actually very little data on what the long-term outcome should be. So I think actually the emphasis for our project on NASH is going to be to identify some of the important symptoms that are reflective of the early symptomatic stages of the disease, as well. Interesting. As well as probably what would need to be measured in post-approval studies, and then there's probably I would anticipate that there's very likely going to have to be some kind of conditional marketing arrangement, conditional reimbursement arrangements, or other mechanisms to systematically follow outcomes that occur later in the disease than the regulatory studies are probably going to actually require.
Please. Yeah, that'd be great if you would.
To both of you, I mean, the evidence being produced is massive. We have the babble of establishing standards, but I mean, the potential with artificial intelligence and that sort of thing to synthesize this. I mean, Dr. Watson was voted Teacher Assistant of the Year, I think, at University of Georgia. Students didn't know who was teaching them, and I mean, that level of sophistication, given the amount of evidence, given the bias that comes from human beings, where do you see that going, and to help inform this difficult process?
Well, I'll have just one reflection on that, which is, as powerful as I think, machine learning, artificial intelligence, real-world evidence are, things like Watson, I still get stuck on the question of, if we haven't somewhere collected the data on the impacts of interventions on how people feel in some kind of, organized way, I just don't see how you come up with, information that's as actionable as it should be, right? Because it seems like at the end of the day, you have to know that. You can't, no matter how powerful the processing is, if you don't know how it impacts, kind of the benefits and harms to patients, and particularly those that are, from a patient point of view, the most relevant, it seems like we're always going to be in a kind of a weak position. That being said, I think there is going to be lots of usable knowledge that comes out of these things. And I guess I would just say, if we take a sort of a forward-looking, longer-term perspective and want to be, smarter 5 years from now than we are now, we'll even use processes like this to identify the key outcomes that will then be, in the electronic health records that become part of what Watson knows, and we'll be, that much better off. I don't know if that makes sense.
Yeah, there's some in the research community, for example, who think we've been trying to design drugs the wrong way, looking at a hypothesis, well, understanding the disease and making a hypothesis, doing preclinical studies, clinical studies, and 70–80% of those molecules fail along the way. So they're starting to think maybe we need to start from a top-down approach. Let's look at the data on the disease, all the patients, all the characteristics, and from that we can create our hypotheses. The issue, of course, as Sean was saying, with artificial intelligence is you need massive amounts of data, and that data needs to be usable data. We've got in the healthcare system all kinds of wonderful data. Is it going to be able to connect together? So there have been some efforts, I know in the US with the Sentinel system, to create common data sets. And I've just heard recently the Drug Safety and Effectiveness Network in Canada through the CNODES group are looking at trying to create a common data management system as well for how we collect this data. I think it'll be very useful when we get into starting to do real world evidence assessments and those reassessments of technologies. The pressure is on to get technologies to patients quicker, and we're going to be having to approve those with a conditional aspect associated with them and reassessing it based on some sort of machine learning model.
Please.
Thank you. I work in primary care. I'm a family doctor. I also enjoy, looking at systems and that sort of thing. So this is, I guess, to you, Dr. O'Rourke, maybe. Is CADIF in their new role as a health technology management expert considering looking at health systems at a more macro level? In the U.S., there's IHI, which is kind of a quality and evidence-based kind of resource for primary care, and we certainly tap into that. But and maybe such a thing already exists in Canada, but I'm not aware of it, I guess. So, is part of your role potentially to consider looking at provincial health systems, like to look at how we deliver health care in Alberta, in all the aspects, but at that macro level, and looking at those same kind of core requirements or core outcomes that are characteristic and are supported by evidence, for delivering better population health overall. Is that part of your intention, or is that not necessarily on your agenda?
A very interesting concept, and we have been asked through the years to help somebody redesign the primary healthcare system of a particular location, and that's a massive project requiring lots of resources, lots of data to do. So let me correct one thing. You said we're a health technology management expert. Well, we're not experts yet. This is a new concept, and we are going to try and learn along the way with everybody else in the HTA field. One of the key concepts, though, that we are looking at is to go beyond that technology, going beyond the device or the drug into more disease state management. And so the scope and the breadth of the work we do will increase. Will that ever get to the point of looking at a system? Certainly we have done work on programs, some health programs, and who knows? Who knows where this will take us?
One other thought, just since I didn't mention it, but I think it relates to your question, is, at least, very big in the U.S. and in European systems. I'm not sure how much this is developed in Canada, but there's an organization called ICHOM, which is the International Consortium on Harmonizing Outcome Measures, which is doing similar work to what we're doing, but the focus is on, measuring the outcomes of providers of care and health systems and having standardized outcomes that one would be used for sort of comparisons about, patients with congestive heart failure or, other common illnesses, like being able to look at a common set of outcomes and how, hospitals or health systems are performing. And then in the whole, thinking about value-based models for healthcare, ultimately, linking payment levels to, the differential performance on the outcomes. So I focus mostly on kind of getting standard outcomes for, clinical development and clinical research, but that are patient relevant and, viewed by clinicians as important, et cetera. There's no logical reason I can think of why those outcomes should not also be the outcomes that are used to kind of target systems improvements and other kind of delivery refinements and innovations. Maybe it's a larger set than you would have in, clinical research. But I still think the notion of, organizing innovations, whether technological innovations or delivery system innovations, around outcomes that matter most to people with illness, is a powerful concept that I can't, doing it any other way. It's hard to think why that would be logical.
Just as well, just as he was talking, you mentioned IHI, and if you look at the title of our strategic plan, Transforming How We Manage Health Technologies in Support of Better Health, Better Patient Experience, Better Value. That's the IHI concept. It's great to see primary care physicians here, primary care docs, community pharmacists, physiotherapists, social workers. You're the face of healthcare. And we probably haven't had enough focus in supporting your needs, your evidence needs in patient care. So that also is a big focus for what we're trying to do with implementation support.
Thank you. Fantastic question. Over, please.
Slightly off topic, but I'm just wondering from your perspective, how's the word cannabis positioned in your mind? So it's just a big thing, and it seems like we're approaching this very, very quickly.
Yeah, we've actually done a fair bit of work in cannabis. You always have to be careful how you say that. So we are starting to get some questions, more and more questions on the medical uses of marijuana, but also some of the policy questions. I think even in Alberta, they've asked us to look at that. I think it's an area that we're going to have to do increasing research on. Are we going to start seeing a lot more public health issues like we saw with cigarette smoking and alcohol? And but all of the medical uses, the primary care docs came out recently saying we shouldn't be using medical marijuana in many conditions. Look very closely at how you're using it. So absolutely, we do have a bundle of projects that we've already done. Everything we do is published, is on our website, except the scientific advice we give to the pharmaceutical companies. That's done in confidence. So if you're interested, there is some work, or you can reach out to our liaison officer, Genevieve, at the back, who can dig that research out for you. The other thing we like to do is we like to broker great work that other organizations are doing. So if we can't find, or we haven't done work in something that you need evidence on, we'll search. We've got a wonderful team that looks and searches the literature globally. So we'll always try and find something for it.
Hi, good afternoon. Thank you for a wonderful presentation. I work in a senior supported living facility, and apparently I'm responsible for quality and innovations there. And we try to focus on resident and family-centered care. So I was just curious, with your 50 stakeholders trying to establish a common core set, did you have any human challenges in working with that type of group?
Did you say human challenge?
Human.
Yes.
Let's see. I think so overall, I would say the process was surprisingly glitch-free. I think that if I'm sort of pressed to think about challenges, it's and this is kind of true for anything that requires collaborative, people from lots of different worlds, is particularly when you get people together, for the first half day, they seem to be speaking the same language, but they don't really communicate. And it just takes a while to realize that the same words from one stakeholder perspective mean something really different, and you don't even know that until you're several hours in and realize, it's like so subtle differences in language and understanding, which you seem to overcome in face-to-face meetings after several hours, but it's definitely, it makes you wonder what the sort of 6 months of work by webinars and virtual interaction were actually about, because I think it was mostly people talking past each other. And so ideally, I think a lot of this work actually has to be done more with, kind of more face-to-face time, because it's just, you bring somebody from the HTA world together with the regulatory world and the clinical community, and they're not used to communicating with each other, and so you just consistently run across misunderstandings that that have to be resolved and before you can actually move towards consensus. So, but I think that's just true for any sort of multi-stakeholder collaborative work.
I think we can all recognise that experience. I'll very quickly, Sean, condition-specific core outcome sets for reimbursement authorities who are dealing with a budget that spans all the conditions. what are the decision makers meant to do when you're giving them detailed information on the benefits to patients of heart attack prevention versus the benefits to patients of hip replacements? Does that really help reimbursement authorities who have got a budget that spans each specialty?
Yeah.
It does outside the US.
Let's put it this way. I don't think we've invented a magic bullet that solves all problems and, kind of resource allocation. I think, so two things. One is I think, we were trying to kind of come up with a proof of concept that at least in one area of active product development, we'd be more likely to have in the future a consumer reports like table that actually had meaningful content, rather than meaningless content. So it was just, it was kind of.
I'm not,
but-
critiquing. I think it's
Right.
incredibly valuable.
But here's the other thing that realizes, and it kind of goes to your that once you've invested all the time and energy to bring all of these very bright, very experienced people together from lots of different places, and perspectives, I think we actually have to ask them some questions that go beyond the outcomes and maybe go more to, some of these broader
choices.
resource allocation policy issues that, because otherwise I think it's an inadequately effective use of people's time and energy and intelligence to bring them all together and at the end of the day only come up with a core set of outcomes.
Yeah.
Because I just think, keep them for another half day, I think they could, solve the energy crisis of a lot of these people. So
Yeah.
I think the work that Sean is doing is incredibly helpful, perhaps outside of the U.S., because the countries in Europe or Canada, Australia, et cetera, that have different ways of looking at, or we can incorporate cost effectiveness work and other factors into our clinical and policy decision making. So really crucial that we have good clinical evidence to start with, because that's always what our expert committees like to have, is that comparative clinical evidence using the right outcomes. We don't want that second consumer report that you showed in the deliberative framework. But our expert committees look at the comparative clinical effectiveness, the comparative clinical harms, they look at the economics, they look at what the patients are saying, and all of those factors come into how they make good decisions.
yeah. And just also to say, while the work I described may sound, a little bit technical and geeky, which it is,
It's great.
but I just, in sort of terms of I think that it is likely that everyone in the room could contribute meaningfully to work like this, because it's the whole premise is this is not an enterprise that requires only expertise. It's an enterprise that requires certain kinds of experience and perspectives, and and that everybody in the room would have something meaningful to contribute. Which I would go on to say is, if anybody is interested in getting involved in one of these projects, just give me your card and we will find a way to get you involved if you're interested.
Thank you. So, Brian, you thought you might be just about getting away without a question? Not a hope. I think it brings back to the point you raised about how this all sits within the system. One of the key determinants is how technologies diffuse into the system. So how does, we're here for doing the right thing right. That's a diffusion issue. In your CADIS thinking about health technology management, where does that diffusion adoption, doing the right thing right, sit?
So to me, it's very different if you're looking at a pharmaceutical versus a medical device or a clinical intervention. With drugs, we all have systems in place, very top-down. There's drug benefit lists, there's hospital formularies, et cetera. All usually the decisions on using those drugs or listing those drugs or paying for those drugs are based on good evidence. We look at the congruence for every recommendation we make that goes out to all the provinces, and it's usually well over 90% of the time when a decision is made by a province to list a drug, it's congruent with the recommendation that we've made. So there is pretty good diffusion there. when you get down to the actual use of those drugs at the clinical level, that's where you can end up with a little bit of diffusion. The way that our systems are set up to report, we know he's prescribed a drug. We don't know what exactly he's prescribed it for in many cases. So is it being used appropriately? And that's where I think we can make some better efforts with this health technology management approach. Now for devices, very different world. Devices are very much bottom up. You could be the CEO of a hospital and have a policy coming for you to sign off on that you had no idea you actually purchased that technology. Physicians are out at major international conferences, they're talking, they're part of clinical trials. So technologies enter the system with very little evidence reviews in many cases. And in a lot of cases, they come from hospital foundations who want to donate something to the hospital. So in a lot of cases for medical devices, I think we are going to have to get much more into, as Justin said, into that reassessment space. Are we making good decisions? Are we using these technologies appropriately? Are they providing good value to the system? And should we actually be disinvesting from that particular technology? So there's a lot of work we need to do in that medical devices space.
Thank you. Ladies and gentlemen, can you join me in thanking our speakers?